Welcome to the CereCore podcast, where we focus on the intersection of healthcare and IT. From practical conversations to strategic thought leadership, let's unpack the decisions, challenges, and journey of those whose purpose it is to deliver technology that improves healthcare in their communities. Today, we are pleased to welcome back to the CereCore podcast, Lynn Falcone and Ismelda Garza from Cuero Regional Hospital. Lynn is the CEO of Cuero Regional Hospital and has been serving as a healthcare leader for more than 30 years in for-profit, not-for-profit, and government hospitals. An advocate for rural health in many ways, but one that's significant is her active leadership on the board of TORCH, which stands for the Texas Organization of Rural and Community Hospitals. Ismelda is the Chief Information Officer at Cuero Regional Hospital and manager at CereCore. A native of Texas, she's been serving for the past 15 years as a healthcare IT leader for critical access and community hospitals. It's great to have you both here today. Lynn, we chatted back in 2023 and Ismelda just last year, 2024, and really so much has been going on at Cuero. It's great to catch up. And for those of you who are interested in the backstory, please check out the notes in the link for previous episodes. So, Lynn, maybe we'll start with you and then go to Ismelda. If you wouldn't mind, just for our viewers and listeners, just tell us a little bit about yourself, your hospital, and more importantly, your community.
Thanks, Phil. It's nice to be here again. My name is Lynn Falcone. I've been the CEO here in Cuero for the last 9 years, which is very hard for me to believe that I've been here for 9 years. Cuero is a great little community who loves their hospital. We're going through just a little bit of growth. We're about 8,100 people now. My hospital is a 49-bed hospital that is very active. We deliver babies. We do surgery. We have a very active emergency department. We also own and operate 5 rural health clinics and own and operate EMS. So a lot going on. We might be small, but we've got our hands out in a lot of different things. We are also the largest employer in the community, and people look to us a lot for what's going on in the community. So it's kind of a nice place to be.
Indeed.
And I'm glad to be here too, Phil. So, you said the last time we met was 2024, and I just can't hardly believe it. It feels like yesterday, just having these conversations. And, just to add to what Lynn said, I've been with Cuero for, I think, 6 or 7 years, and that time frame goes by so quick. Just a quick story on that. The first time I met Lynn and team, and I was there to do an IT assessment, and after it, I was presenting my findings, and Lynn had said, if you could describe in one word this assessment, how would you describe it? Or the one word for the hospital, how would you describe it? And that stayed with me. And I thought, how do I tell someone that their baby is not as attractive as they might think the baby is, but the baby is going to change?
The baby's going to grow up.
That's right. Excellent analogy.
So, it was definitely just a lot of room for improvement. And 6, 7 years later, here we are with implementation of Expanse, and it's been good.
Oh, that's excellent. Well, and you mentioned that it's been quite a transition over the years, and it's a multi-year journey, not only just for complete IT, but also on the EHR side of things. And as you mentioned, you've moved to MEDITECH Expanse, implemented their ambulatory, and just really the optimization efforts that you've been really navigating through, or helping make it even better. So, maybe to level set, Lynn, help us understand what your goals were for investing, in the new EHR. I remember you were eager, to get some additional data into the hands of your care providers. So what's it been like kind of before and now after from a go live standpoint?
I think when you look back over the build and the implementation, it's always a challenge, right? But when we were going into this, we set out that, yes, we wanted to have data. It was important for us to be able to learn more from our own system and be able to pull some data out. Mm-hmm. We were very focused on bringing our 5 rural health clinics that I mentioned a few minutes ago and the hospital on the same platform that addresses efficiencies as well as patient safety. And then, of course, the other goal was being able to offer a safer environment because of the way we document and what gets captured and what kind of flags and what have you could come out. And I think as I look back over it, I would say we were very successful in that. Not that the road wasn't bumpy at any given point in time, but those were kind of the goals we had going in. Getting on one universal platform was incredibly important for us because we have patients that basically come across the hall from clinic to the hospital, and the challenges that we had with that are now much better off.
No, that's excellent. Ismelda, if you wouldn't mind, just tell us a little bit more about the why of the technology journey. Why Expanse? Why now? The timing of that, and then really, why did you need some partners along the way as well?
Okay. Phil, I think that, the biggest part of the why is I think our legacy systems were getting in the way of patient care. Mm-hmm. So we had 2 different systems to maintain and support. The clinicians in the ambulatory had one, hospital had another. A lot of those providers go back and forth. And so, and just nothing was consistent. So we want the system, we have a system that we're able to provide as a tool to the clinicians to help take care of the patients and it not be a challenge or a hindrance to them. So when I look at it in the why, and it's really not about technical requirements, it's more about how are we taking care of our neighbors? How are we providing them trust? How are we looking at safety and providing excellence, which is part of our mission? Another piece of that is we just needed a lot of that flexibility that we didn't have with Magic. We needed some of that scalability, mobility, and again, the ease and the consistency. Like Lynn mentioned, having that single patient record, that was really, really key for us. We just really saw how that could help reduce some of the duplication and minimize some errors. And the reason I think why we decided the now, a lot of it was there wasn't a day that didn't go by that someone wasn't saying, can we make this change? Can we do this? Can we get this? Can we get this integration? Can we have this talking, all these things. And every time we'd say, let's wait. We basically were asking staff to kind of come about with some maybe manual workarounds, or maybe they were rekeying data or chasing down charts. I mean, it was just a lot of that going on. And I think that when you look at it from that perspective, that cost, it's very invisible. So it's not something that you see, but it's such a real challenge, right?
Well, I would also add is the why now. Now took a long time to get there. And you heard Ismelda say it's been 6 or 7 years and my baby wasn't very attractive, is being able to build our infrastructure to be able to support a new modern EMR took a really long time to get there. And we were able to finally get to that point. And as people saw that it was becoming real, Ismelda mentions that, okay, they come up with a workaround here, sit tight, we'll get to it. And as I mentioned, the patient safety end of it, when you get workarounds, you get a risk of not having the safest environment that you can possibly have. And so Expanse has helped us conquer some of those and build some new needs as well. I'll be very honest, and everybody needs to understand that your EMR isn't going to be like this magic bullet that fixes everything, because you create other challenges as you go. But it took a while to put the makeup on my baby so we could get this going.
Well, the analogy I like to use with that is that we were operating on a body, living, breathing, that did not have anesthesia. So that was a difficult place to be, and it took a long time. But, once that infrastructure was in place, like now it's like, all right, now we're ready to go. And this is why, and you asked me, why did we choose the partner that we chose? And that was CereCore, for consulting, to help us implement this MEDITECH. And really, like, the way I see it is, we're not looking for, someone to just install software. We wanted individuals, a company, a vendor that understood our realities, our challenges, our staff shortage needs, somebody that could walk with us from our planning of go live to until we are today. And I really, I think that Lynn and I can both say that CereCore brought that. Not only from the MEDITECH expertise, but they also had that deep operational understanding that these consultants were, they've been at other hospitals, they've been at other clinics, they see what it takes. And so it was really instrumental to our success to help to have them help us stay on track and meet our deadlines. And then, just and help supplement in some of the staffing that we were having some shortages in, and then also just all the competing priorities. I mean, you have this big project going, but nothing else stops. We're still going. Everything else is still going.
Exactly. Yeah. Exactly. No, and it has been a journey, and it's been fun to watch as, Lynn, as you took over the organization, and then Ismelda, you came in, and then all of a sudden things started to happen, right? And this all of a sudden got remediated, and this got fixed. And then you could all of a sudden start to see your team and your staff kind of get excited, right? And then they bring it, hey, what about this? What about this? What about this? And, so it's been very nice to see that transformation for Cuero and an organization, and where it was to where it is today. It's been truly transformational. And I think, part of that, Lynn, you've talked a lot about your vision for Cuero as a highly reliable organization. And, what's a good starting point or a goal for people, culture, mindset when it comes to a change like that?
Well, high reliability is just as it sounds. You look at the healthcare industry and you look at, the airline industry, and they're very high risk. Yep. So what do we do to reduce our risks every day when we take care of patients? And some of our activities in a healthcare system are not as risky as others. Registering a patient versus giving blood. And as I mentioned, the way that a new EMR would support us versus our old one would help us assure we were doing better. We embarked on truly high reliability organization, which is developing a culture of being obsessed with no patient harm. And part of that culture is when you have a near miss or you catch something and it doesn't get to the patient. There was a day that, oh, you didn't talk about that because that might cost me my job. Today, I think we're more successful in our high reliability, I call it HRO, quest, coming through our EMR build, because that was a time that we built teamwork and we built communication, and our leaders and our staff quickly realized it's not all fun and games, and it gets ugly and it gets challenging and you're going to want to quit and you're going to cry. That we built that core, and starting our quest of high reliability and really that culture where it's okay to talk about those. And not only is it okay, it's expected, because how we can fix it to keep our community coming back here. We are blessed with the opportunity to care for this community in this county. We need to do the very best we can. So as I mentioned, safety was one of my key quests going into it. Is we're at the point now where with HRO and learning skills and with the information we can gather, we're totally refining that. And it's nice to see how the team has grown, staff that have been involved, as well as our leaders. That to me, it's very exciting. And the benefit is ultimately for our patients.
Yeah, no, that's excellent. So Ismelda, there's obviously an IT portion to this, right? Supporting that high reliability organization initiative. So could you give us an example or two about how IT is supporting that?
Yeah, absolutely. So, I mean, ours, from an IT standpoint, it could be as very basic as computers that have just been aged and need to be replaced with something newer, or scanners that aren't working as well in the ER. There's just so many little things that IT is so involved in that contribute to the high reliability. And so I think that, we talk about what the Expanse implementation, but it's so much more than that. And there's so many initiatives, with we had that one example in ER and just replacing one computer, how much it had improved a clinician's experience in taking care of a patient.
Oh, that's excellent. Yeah, it definitely goes well past the EHR, and I think for those folks that are not in the healthcare space, I think people would be amazed at just the vastness of all of IT and everything it touches anymore inside of a hospital and a health system. So, and I'm kind of curious. We talked a little bit about the non-EHR side of things. The EHR transition, certainly was significant for you guys, and I'm assuming it's a big kind of anchor component of this move and direct path towards high reliability in the organization. Correct?
Absolutely. Not only from the teamwork standpoint, but as Ismelda mentioned, that we're talking more about, and even if we look through the optimization piece, or we look at how something got built and like, oh, wow, this isn't happening, we can't have that. People are quick to say, hey, how can we fix it? Versus, oh, there's a whole nother issue that can't get fixed or something. That I feel like staff are more proactive and willing. I think Ismelda has helped build a great team in IT that's been, they get hospital operations, they get the clinical operations, and it really, I tell them every day, it takes a village. It's not just one person. It takes a whole village to make it work.
Yeah. And I would add to, one of the things that we do is we want to hear the issues. Tell us. Very open door about that, because how do we become better if we don't hear that and know that, right? And so we, it's weird because we did go live in August, so we're full blown optimization.
Right.
We had a shaky start in our clinics with just some of the systems, and it was a bigger change for our clinic staff than it was for the hospital. And so, definitely, but we're in such a better place just from August until now in how the doctors are talking about the system and using it. And, and it's just, I really am confident that every day is going to be a better day.
Well, I really appreciate you all, talking about how going through a major program implementation like this really impacted the teamwork at the organization and almost got people thinking a little bit differently about bringing forth ideas and bringing forth optimization and taking ownership of some of that stuff. And, as we know, IT is always changing, right? Computers are always going out of fashion. They're too slow. But, EHR major systems are no different, right? You mentioned it. They're not static. They need optimization, and that really, never stops. So, maybe Lynn, you can start, and Ismelda, follow up with some additional items. Just practically speaking, how do you kind of build the governance, the framework, the structure for the organization to keep that momentum going when it comes to that continuous improvement?
Well, I think there's a number of ways that we have the structure now with the team in IT and the people in each department that were so involved in the build and the design and the implementation that they know I want this change or my doctor wants this change, and he's jumping up and down to make sure that we get it. But if we get it, something else could not work, or what are the repercussions of that? So having everyone understand that and being able to take it through to look at that. And then Ismelda is really good about saying, okay, let's put it in the test environment and let's let everybody test that. So they understand it's not, I'm going to jump up and down and get my way to make it work the way that I want it. Although some try to do that, I'm not going to lie.
Oh, sure. Of course. Of course.
And they all have Ismelda's number and my number, and they're going to message us any time of the day and night. But so having that structure and having everybody have that common understanding to say, hey, I want to make this change, or hey, this happened from a potential safety event, you've got to have that governance structure to say, what does it take to make that change?
Right.
If not, I would say we would break something really quickly.
Indeed.
Yes, because the wish was one record and the challenge is one record sometimes. But I think a lot of it is like we communicate. We still have change control meetings once a week. We have huddles every day. The doctors are able to contact us at any time they would like, whether it be through a Teams message or a text or a phone call. Just really making sure that they're feeling supported. They know that they're supported, not just feeling, but know that they are supported and are seeing actionable items. Just really, I was just thinking when Lynn was talking about that, because we did come from before everyone had their own customized order set. And so you move fast forward to Expanse, and that's not happening anymore, so that was definitely a transition. We just communicate.
And I think in that communication and going back to the doctors and making sure our doctors feel like they're supported and they're heard is, they were frustrated. It's a more, as implemented, it had a whole lot more clicks or different clicks where they didn't have to click before. and really walking through the system with them and looking at the implications. Well, if I shut that off, here's what this happens. And being able to get the people who can help talk their language versus, I'm going to go complain to the CEO because she'll fix everything. That's not my specialty. I'm not the clinician, and I want my doctors happy, but I don't necessarily want to have a system that doesn't have fail safes in it or, a number of different things. And so really working together, being able to get someone that the docs can have and can make some of those great changes that make them feel better and say, okay, yes, I am listened to. And yes, it is important to them. It's not just all about the big hospital. It's also about the clinics. And I think that as Ismelda mentioned, that the ambulatory was a bigger challenge for us. It was a bigger lift with a bigger change from a different system. And it was a beloved system to some and a hated system to some. So, yes. But we're definitely in a better place now.
No, that's excellent. That's excellent. Well, I wanted to pivot just a little bit to, I guess some would call it the hot topic that everyone seems to be talking about, and that is AI. And so, Lynn, you recently came back from the big annual torch meeting. What's the AI conversation among?
Well, AI is always a hot topic, as you mentioned. I think yes. The last 2 or 3 torch meetings I've been to, AI was a major topic, and I think everybody's ready to say, how can it help us in a rural setting? How can it help us because staffing and recruiting is so challenging? It was very interesting this time around that there was a speaker talking about more of the pitfalls, and if this happens, and if you're actually looking at replacing doctors, no one can sue AI. So it kind of gave you a little balancing effect. Right. Ismelda and one of our doctors here have really focused and looked at a number of different companies that would be a scribe. My doctors will say, if I had somebody else to do the documenting, I could go much faster. Well, if I can't recruit staff, it's hardly that I'm going to be able to recruit a scribe, but an AI scribe, might be a really good alternative to be able to help and support them through their patient care. But highlighted at Torches, what are the pitfalls of that? And, what are the things we need to look at? And I don't think we're quite there, or I don't think systems are quite there for what we want to look at here. And Ismelda can probably give you more technical on there. But it's definitely, in terms of that AI scribe, is something we're definitely watching.
That's excellent. Yeah. And Ismelda, I'm sure you get questions all the time since being the CIO, right? Well, hey, what about this AI? What about this AI? How do you handle that? What's the, what advice would you give other CIOs and how to handle all of these questions around AI that are coming through?
One question at a time, so like Lynn mentioned, we've, one of the doctors and we've demoed several, and, they're slick. They're really nice. They're very, they parse out the good things and they parse out all the, fluff. And so it's really neat. It isn't going to save any time based on what I'm looking at, not for what the doctors are looking for. There is a lot of still cut and paste components from an EMR side, and then that's going to obviously affect how we pick up some of those value-based reporting, quality reporting that we need. And it's going to require more hard stops. And so I don't know that that's going to be the answer just yet. But there are some other ways of AI too that from an IT shop we're looking at, and that's, even looking to see when someone calls in the help desk and how they can use the AI to help them work through general issues. And so we're looking at that, entertaining that. I think it would be very helpful, especially since we do have a lot of competing priorities, and it would make sense for us. But yeah, I think there's potential, but the biggest thing, for me, and I'm just very realistic and just very practical, and it all has to do with cybersecurity. It is big, it is real, it is something we have to pay attention to and vet any product through.
Yeah,
I would also jump in and add that, after 2 torch meetings ago, I came back going, oh, we got to look, we got to do this, we got to try. And I think for any CEO that's looking at it is make sure in your CIO, IT director, whoever you depend on for your information technology is have a good relationship and have somebody not afraid to tell you like, okay, simmer down. We'll look at some vendors, but you got this copy paste. And I think that is one thing where Ismelda has been so valuable is like, I'll come in all excited and I'm going to press. And she's like, okay, let's take it one step at a time. And, I think she wasn't afraid to go look at some of the vendors for that. I think across our hospital, there are people who use ChatGPT for other documents, not necessarily in the medical record. And I'm like all for it as long as you clean it up and you make sure it sounds like it's you speaking. But
right. No, I think that's really, really solid advice. It's one of those areas where people get really, really excited about it. But you have to have a use case and you have to validate the use case, and you have to certainly take into consideration the cybersecurity elements associated with that. And sometimes it's tempering that enthusiasm and that excitement and walking through your traditional evaluation process for each and every one of these. So I think that's great advice for everybody. You guys have been through just a lot of major change, and, from an IT perspective, and all of that, takes, really it puts a lot of stress, on the organization, on individuals. You've mentioned a few of those, maybe points of frustration or concern, throughout this conversation even. So, would you have any words of wisdom or guidance for the listeners, just in and around as they're moving into a period or a time of a large program change or project that's going to be stressful? What are some of the things that they should consider?
I think number one is it's got to be communication. If you can't get out to describe the project and the why behind we're undertaking a project and why am I about to stress you out, you've got to be able to communicate your team and get them on board going forward.
Right.
And keep them on board as you go. And even if you hit a pitfall or something happens, you've got to say, okay, so this happens and we're going to pivot and we're going to go this direction a little bit. That's in some sense, it's a lot easier to do in a rural hospital or a smaller organization because you've just got fewer people to have to figure out how to communicate to. On the other side of that, the more challenging end of it in a rural situation or a rural organization is it's everybody's organization and they maybe have been here for 30 years. And if they've only been here 5 years, it's their organization and everybody knows everything about what's going on, or at least they think they do. And so really being able to set the story straight and keep them on board and keep them engaged, it all flows back to communication.
No, excellent point. Excellent point.
That saying is true. Everybody dies famous in a small town.
Yes. Well, I guess that leads me to my next question, which is perhaps a little bit more lighthearted. But you mentioned small town, Cuero, Texas. So, what are some of the biggest misconceptions that people who don't live where you all live, What would they have? What would some of those misconceptions be?
Well, I will use my daughter as an example. And she said, "How many stoplights are in town, Mom?" Now she's been here several times, and it's not it's more rural than she will get. But I think if I focus it on healthcare, many people think rural healthcare is not quality healthcare, and you don't have the resource to do it well. I've heard plenty of horror stories. I stopped at a hospital between point A and point B, and this happened. And I think that's what's made me so driven in my organization to focus on quality and safety and making sure we have the tools there. I would invite anybody into my organization for healthcare. I've had my procedures here. I've had plenty of healthcare. My family has actually come to Cuero for healthcare. So I think from a rural healthcare perspective that is the biggest misconception, is that if you're small, bigger is always better. And I would say when you come here, you're not a number. You're really the person that we want to take care of. So that's a big misconception that I think in a healthcare setting you've got to deal with. Ismelda, what would you add?
Yeah, I definitely 100% would agree with that. I think also a misconception is rural healthcare, you're not going to be busy. Just whether it be in the ER or even in IT, it's just a complete opposite of that. You're seeing so many different situations in an ER setting. Coming to a rural healthcare for ER is, if you want a retirement, that is not going to happen.
Exactly.
Yeah. So, and then I think the other one would be, just real quick, is that we don't face the same challenges that maybe a taller hospital would. I think we do. It's just I feel like in a rural healthcare setting, though, I do have to be a lot more innovative in the things that we have to do because of budget constraints, staffing constraints. There's so many more constraints.
Yeah, I agree that people wear so many different hats that what they're going to do next isn't always what's expected.
Right. I think you made mention of a few things earlier on in our conversation, and there truly is a sense of community, right, when it comes
Absolutely.
to rural healthcare. And I think in some of the urban settings, there's a tendency for it just to be a job, for it to just you go in, you do your job, you punch out, and that's it. I've had the privilege of doing a number of these conversations with a number of individuals, from CEO to doctors to, chief nursing officers, et cetera, from a rural standpoint. And the one consistent message and theme that comes through is that caring for the community. All up and down, from the C level all the way down through, whether it be janitorial staff, whether it be you name it. It's about caring for the community. And when you have that sort of mission-driven organization from a rural health standpoint, it makes all the difference in the world. I was blown away when I was talking to one of the doctors, and he was like, "Oh yeah, I routinely on the way home stop by and see this patient and this patient and this patient because I know they can't get to the facility." I didn't even know that existed anymore. That was so refreshing and neat to hear. So, well, thank you for sharing that. We always like to wrap these up. And I never want to wrap them up, but we always have to. With just kind of a final call, was there anything that we didn't talk about today that you wanted to share? Any last words of wisdom for our listeners?
No, I think we covered it. Ismelda?
I think the only, I would just say, just a reminder, if you're going down this process, you're considering this, just be agile, be adaptable. This is a cliche, but it's so true. It's not a sprint. It is a marathon. We're still living it. We're still,
Right.
going through it, but and always have fun.
You always have to look for the bright side.
Yep.
Indeed. Now that's excellent. Well, Lynn, Ismelda, thank you again for taking your time and sharing your insights with us. It's been great. It's been wonderful as always. And thank you.
Thank you, Phil. Thank you for having us.
Thanks for listening to the CereCore podcast. We hope you enjoyed this conversation. Follow us on your favorite podcast platform for more episodes. Connect with us on LinkedIn. Visit our U.S. website at CereCore.net. And for those abroad, visit CereCoreInternational.net. Learn more about our services and find resources. At CereCore, we are healthcare operators at heart and know the difference that the right IT partner can make in delivering quality patient care 24/7. Let's help make IT better. Here's to the journey.